Morning. Today's topic is femoral shaft fractures. It was supposed to be taken by Dr. K.J. Krishna Singh. Diving right into it. Coming to anatomy of the shaft of anatomy of femur. It is a long tubular bone with an anterior bow forward and has an oblique course from the neck to the distal line. Coming to the muscular attachments in different compartments around the thigh. The muscles in the thigh are organized into three different compartments. The first is the anterior compartment of the thigh, which contains sartorius and four large quadriceps muscles. The sartorius, the action of sartorius is flexion at hip on all the four quadriceps muscles, including vastus lateralis, medialis, and intermedius, along with rectus femoris. It covers extension at the knee. Coming to the medial compartment of the thigh, it is predominantly dominated by adductors of hip, like adductor longus, adductor brevis, adductor magnus, and obturator externus. Obturator externus also causes lateral rotation of the thigh. Coming to the posterior compartment, it has three large muscles which are termed hamstrings. They are semitendinosus, semimembranosus, and biceps femoris. And their main function is flexion at knee, and also extension at hip. This is an axial cut of the plane of thigh, which shows different muscles in their compartments. As you can see. Moving on to the nerves and vessels. This is a femoral nerve and vein and artery, which are organized in the same order from medial to lateral, which supply the thigh and distal compartments. Coming to the fractures of shaft of femur. A femoral shaft fracture is a fracture of the femoral diaphysis, which occurs 5 cm distal to the lesser trochanter and 5 cm proximal to the adductor tubercle at the distal part of femur. Epidemiology, it is the most common injury due to major violent trauma. Because femur is a very strong bone, it requires a violent trauma to cause any kind of fracture in the shaft. The incidence is usually 1 in 10,000 people, and it is more common in people of less than 25 years of age, owing to more active lifestyle and road traffic accidents, and people above 65 years, leading to initial signs of osteoporosis and all those things. Psychological fractures are more common in elderly males and females. These are the most common causes of fracture of femur. Motor vehicles, motorcycle, auto pedestrians, fall from height, and gunshot wounds. Gunshot wounds are relatively rare, but they are more common in military accidents. Coming to mechanism of injury, in young adults, there is always high energy trauma following a motor vehicle accident or a gunshot injury or a fall from a significant height to cause fracture of the shaft of femur. And elderly patients usually present with pathological fractures, which commonly occur following a trivial fall. And stress fractures occur mainly in military recruits and runners due to constant marching and all those things. Coming to the symptoms, there will be a diffuse to severe pain or ache at the site of the fracture, and we can elicit tenderness and swelling in the thigh or the groin depending on the site of the fracture. Bleeding and bruising are usually uncommon. They only occur in compound fractures. Weakness and inability to bear weight on the injured leg owing to the fracture, obviously. And we must check for any paleness, because if there is any paleness, then we should suspect a neurovascular injury and it should be tended to promptly. And clinical evaluation. A full trauma survey is usually indicated. ABC is airway, breathing, and circulation. We must maintain the hemostasis of the patient along with blood channels and airway. The patient is usually non-ambulatory with pain. He cannot walk because owing to femur being a major weight-bearing bone of the body. And there is a variable gross deformity of the thigh and swelling at the site of the fracture. And shortening of the fracture, there will be shortening of the affected extremity. Because of muscular action, there will be overriding of the different fragments of the femur, and we will get into it later. And a careful neurovascular examination is essential. As you have seen in the anatomy, femoral vessels and nerves are usually anterior to the shaft of the femur. Any fracture of the femur we should carefully examine neurovascular structures passing in the thigh by checking the distal pulses and all that. And a careful assessment of hemodynamic stability is essential. Average expected blood loss is 750 to 1500 ml, depending on the injury to the vessels. And a thorough examination of the ipsilateral hip and knee should be performed. Any knee ligament injuries are usually common, and they need to be assessed after the fracture fixation. Coming to associated injuries, you must check for an ipsilateral fracture of femur neck, and it is okay distal femur fractures. And fractures of patella, tibia, acetabulum, and pelvic ring are usually common. And soft tissue injuries around the knee, particularly ligamental injuries, collateral ligaments might get damaged along with ACL and PCL because of the high velocity trauma. And the thoracic and abdominal injuries. Coming to the investigation, X-ray is usually the diagnostic investigation used, and we will confirm the diagnosis and establish the size, line, extent and displacement of the fracture using an X-ray. We will get two views for all fractures, AP and lateral views of the femur, hip and knee. AP view of the pelvis will also be obtained to rule out any pelvic fractures and any other fractures. We must look for evidence of associated femoral neck or intertrochanter fractures and knee injuries. This is a fracture at the proximal end of the shaft of femur. As you can see in anteroposterior view, this is the anteroposterior view and this is the lateral view. In the anteroposterior view, because of the action of the gluteal muscles, which is gluteus medius and minimus, they will abduct the fracture fragment, the proximal fracture fragment, and the shaft of the fragment, which has attachments to the adductor brevis and adductor magnus muscles, which are in the medial compartment. They are primary adductors of the thigh. As a result, the proximal fragment is abducted and the distal fragment is adducted, which gives rise to a fracture displacement pattern like this. Now, coming to the same fracture in the lateral view, the action of the iliopsoas muscle will pull the proximal fragment anteriorly, which will cause an anterior angulation of the proximal fragment, whereas the distal fragment remains straight because of the stabilizing factors of rectus femoris and biceps femoris muscles. This, as far as the fracture in the proximal fragment goes, this is how the X-ray picture will look like. Now, coming to the shaft of the mid shaft of the fracture of femur, in the anteroposterior view, the action of the gluteus muscles will be counteracted. Action of the gluteus muscles will be neglected because the adductor muscles, the insertion of the adductor muscles will be along the shaft of the femur, and the fracture, it splits the insertion of the adductor muscles, which will stabilize the fracture fragments in the anteroposterior plane. Coming to the lateral view, the psoas and the iliacus muscles will have unopposed action in anterior angulation, in flexion of the hip, which will cause anterior angulation of the proximal fragment of the femur, and the distal fragment will be stable. So the picture in mid-shaft fractures will look like this in an X-ray. Coming to the distal part of the fracture, as you can see, the displacements are quite similar to what we will see in the shaft of the fracture. And because of the prominent action of the adductors, the adduction of the proximal fragment will be seen in case of distal fractures, as opposed to the flexion in all the other cases, abduction in all the other cases. Coming to the types of fracture, oblique fracture. The oblique fracture is any fracture which has a line demarcated between the medial and lateral margins of greater than 2.5 cm is considered to be oblique, as you can see. Less than that is considered to be transverse, and coming to fracture there will be more fragments. This is a spiral fracture which leads to, because of a twisting injury, which will lead to a formation of a butterfly fragment. This is a compound injury with breakage of the skin, which will lead to excess bleeding, and because of angulation. Coming to classification was proposed by M.B.B.S and Hansen in 1984. There are 5 types, beginning with type 0. Type 0 is a simple fracture with no combination. And type 1, there is an insignificant butterfly fragment with transverse or short oblique fractures. In type 2, there is a large butterfly fragment that is with butterfly fragment of less than 50% of the bony width and greater than 50% of cortical contact. And type 3, there will be a large butterfly fragment leaving less than 50% of the cortex in contact. That means the butterfly fragment will be displaced far beyond the initial anatomical location of the shaft. In type 4, there will be segmental combination. These are the different types. Coming to the management in children. In infants, any stable or undisplaced shaft of femur fractures can be managed with splint, with a simple splint. And in infants with unstable or angulated fractures, a Pavlik harness or gallows traction can be used. This is a Pavlik harness. As you can see, the hip and knee are flexed and abducted, and they are held in position by a chest strap and different kinds of straps. That is a desirable position which the infant should be kept for fracture healing. It is usually done in infants of less than 6 months of age. And from 6 months to 5 years, we will go for hip spica cast. This is gallows traction. The weight of the baby is used as a counter traction to keep the fracture fragments from overriding. And this is the thumb splint. It's usually designed for each and every baby, ideally. Now, coming to management of shaft of femur fractures in 1 to 6 years age groups. If it is a stable fracture, spica cast and gallows traction will be acceptable. And if there is a chance of multi-trauma with possible multiple fractures, then fixation with intramedullary nail is used. Usually tense nail is better in pediatric cases because of quick healing. And in 6 to 11 years, if there is a high energy trauma with unstable fracture, then plating or external fixator or a flexible nail should be used depending upon the condition of the skin and the ability of the patient to bear weight initially. And in patients greater than 11 years, internal fixation with an intramedullary interlocking device is usually advisable. This is a flexible intramedullary nail fixation, which is called as tense nail, titanium elastic nailing system. As you can see, the entry is taken at the distal end, and the nails are pre-bent to contour the medullary canal, which will push the inner sides of the cortex towards each other and will maintain the reduction. And in non-cooperative adults, those who are not willing for surgeries, we can keep them in a skeletal traction of Thomas splints, and cast breasts are usually uncommon. This is a pre-surgical management in whom surgery needs to be delayed and temporary stabilization is desired. See, a sham pin or a bowler pin is inserted two finger breadths below the tubercle, through and through from the lateral to medial side, and then it is attached to a bowler stirrup, and along the angle of the shaft of femur. See this, the weight should be pulled along the length of the femur, not along the length of the tibia. That is at a 45 degrees the plane of the bed. Now, the other operative fixation options are intramedullary fixations or open reduction plate fixation, and each fracture is different, and depending upon the deforming forces at the site of the fracture, a surgeon must make a decision as to which operative method he is to follow. In case of skin loss or infected fractures, external fixation is usually preferable. This is the most common mode of management in young adults who present with shaft of femur fractures, that is intramedullary nailing, intramedullary interlocking nail. They come from sizes ranging from 8 to 12, that is the diameter of the nail, and the entry is taken from the piriformis fossa, and after progressively reaming the medullary cavity, the intramedullary interlocking device is inserted. It will have 2 screws at the proximal end and 4 screws at the distal end, 2 oriented along the mediolateral axis and 2 along the anteroposterior axis. And with the help of a CR or immunofluorescence device, screws are fixed at the anterior and posterior ends, the proximal and distal ends. Now coming to plate fixation. Plate fixation is not usually indicated for long and strong bones, but these are the few indications for plating. The patients who have an extremely narrow medullary canal, like young females, all those, and those age groups, and the fractures aren't and any previous malunions. Malunions, if you do an interlocking intramedullary device, they won't heal properly. Fractures extending proximally or distally into the puptocantric or metaphyseal region, and ipsilateral neck fractures. These are some indications for plating. This is a post-operative X-ray in a patient where a locking plate has been used. And the external fixation. Whenever there are severe soft tissue injuries to the skin and the surrounding soft tissue, the time needs to be donated, time needs to be given the soft tissue to heal before the fracture of the femur can be satisfactorily fixed. And if there is any contamination of the wound, which will lead to possible infection and further osteomyelitis, it needs to be controlled before a definitive management can be done. And any associated vascular injuries and a polytrauma for exome fixation is a better choice. Coming to complications, these are the general complications which result in any fracture, not shaft of finger alone. Blood loss, shock and fat embolism, and acute respiratory distress are common in high energy injuries. Coming to specific complications, vascular injury, we've seen the course of the femoral lateral and anterior part of femur, and any nerve injury to the femoral nerve, which may be hydrogen or in the surgery. Femoral, sciatic and pudendal and peroneal nerves are usually commonly injured. Thumb embolism, which is a sequel of fat embolism. Compartment syndrome is usually very rare because the thigh is a very accommodating area. You have plenty of soft tissue to contain the edema, so compartment syndrome is not usually that common in the thigh, but still it is a possibility in at least 1 to 2% of the patients. And infection, any compound fractures, they always run the risk of infection. And delayed union and non-union. Joint stiffness, knee and hip pain due to prolonged immobilization of the knee even post-surgery. And hypertrophic calcification. Thank you.